Hello, and thank you for joining me for this session today. My name is Dr. Kyle Smoot, and I'm an MS specialist at the Providence MS Center located in Portland, Oregon. The goal for this program is to review treatment options for patients with relapsing forms of multiple sclerosis. I think that this video can be very helpful, especially for patients who are initially diagnosed with multiple sclerosis and for those patients that are currently on a therapy and are having side effects or potentially having progression of their disease. The video potentially may be long for some as there are many treatment options for multiple sclerosis. Fortunately, the options continue to expand since our first medication was approved, which was beta-seron in 1993. Because this video is recorded, it gives you the option to scan through the video per your leisure. There are different forms of relapsing multiple sclerosis, clinically isolated syndrome, the relapsing or remitting form of the disease, which is the most common form, and active secondary progressive multiple sclerosis. These diagrams nicely point out the different phases of the disease. On the far left diagram, you'll see a bar of orange, and this signifies a first or initial relapse. For example, a patient may present with an episode of visual loss and pain with eye movement, which is commonly called optic neuritis. If patients undergo an MRI at that time and lesions look consistent with multiple sclerosis, a diagnosis of MS is made, and we do recommend that patients initiate treatment at that time to prevent further relapses. Sometimes patients will have another relapse prior to a diagnosis, and it's possible if patients continue to have relapses over time, this may result in more neurological symptoms and disability, which is outlined on this diagram. This would be an example of a patient who is not currently on disease-modifying therapy. Again, relapsing remitting form of the disease is the most common. Roughly 85% of patients present with this stage of the disease. The goal of treatment is to prevent progression and the transition to what we call secondary progressive disease, where the disease slowly worsens over time, which is outlined in the diagram on the right. Between relapsing remitting and secondary progressive, patients can have relapses, although they're relatively uncommon, and this is called active secondary progressive MS. And the treatment options that we have for relapsing remitting MS may also help with this phase of the disease. However, the disease slowly progresses where there are no longer relapses, and unfortunately, medication options are extremely limited with this phase. The other phase of MS, which we're not going to speak too much about today, is primary progressive MS, which occurs in about 10% of patients, and patients typically present with no history of relapses. Their disease slowly worsens over time. Mostly, patients notice problems with walking. So again, there are multiple treatment options for relapsing MS. And I'm going to briefly review the options that are available and then go into them in more detail. I've broken them up in terms of how well they work or their efficacy. On this slide, list what we call platform medications. These medications have been around the longest, including Glatiramer acetate, which is Copaxone, and then we have several medications which are called Interferons, Avonex, beta-seron, Rebif, and Plegridy. Again, beta-seron was the first medication approved for the relapsing forms of MS, which was in 1993. Another injectable therapy is called Ofatumumab or Kesimpta, and this is also an injection, and it's very similar to Ocrevus and Rituxan. And of course, I'll speak more about all of these in a few minutes. We also have oral medication options. There are four main classes. One is called the Fumarates, and most people are familiar with Tecfidera and its cousin Vumerity. There's also a medication called Teriflunomide. The other name is Aubagio. And then a medication called Cladribine, and its marketing name is Mavenclad. And then there's a class of medications called the S1P agents, and there are four of them. The first one that was approved was Gilenya in 2010, and since then there have been three others approved for relapsing forms of MS. And then lastly are infusions. And there are four infusions: Natalizumab or Tysabrl, which has been around the longest for the treatment of relapsing MS, Alemtuzumab or Lemtrada, Ocrelizumab, which is Ocrevus, and Rituximab, which is Rituxan. So as you can see, there are many treatments that are available for relapsing forms of the disease. And a lot of, in terms of picking a treatment, can be challenging, and there are a lot of factors that play a role. One is how a patient is doing. So typically if a patient's presenting with a more severe relapse, such as having problems walking to the point that they required hospitalization, then we would lean towards using what we call more high efficacy medication. If there are a lot of MRI changes in the brain, or potentially if there are changes in the brainstem, which is the connection between the brain and the spinal cord, or changes seen in the spinal cord, then we'd also be concerned about the disease progressing at a more rapid rate. So using a higher efficacy medication would be ideal in those situations. Also, if the patient has had several relapses within a year prior to presentation, that is potentially another poor prognostic marker. Race and sex also play a role in treatment decisions. African Americans or Blacks potentially may have a more aggressive course, and typically men do not do as well as women. Family planning also is another factor. There are some medications that may not be ideal to start if a woman is planning on having a child in the near future. And really, most of our medications are not recommended during pregnancy or breastfeeding. Fortunately, most women do quite well during pregnancy, so medication is typically not needed. And then looking at medical conditions. So if someone has several medical conditions, then they may be more prone to having side effects or potentially more prone to have infections related to the medication. Age also plays a factor. Unfortunately, as we get older, our immune systems are not as robust, which puts us at more risk for developing infections. JC virus status. Some of these medications can be associated with a brain infection called PML, and that's triggered by a virus called the JC virus. And I'll speak more about this later on. In patient preference, there are some patients that prefer to take a pill every day. Other patients prefer to go in for an infusion, and actually some patients do not mind doing an injection. And then another factor is insurance. And what I tell patients is, let's make a decision together based on what we feel is best fit for you. And then we'll work out the insurance piece. Fortunately for people that have commercial insurance, there are adequate copay assistance programs, so most patients pay very little or nothing for medication. And if medication is not covered, a lot of times your clinician will work with you to file an appeal to get the medication approved, and many pharmaceutical companies will offer what they call a free drug program. So again, there are many factors that play a role, and I think it's important for you to work with your clinician. In my clinical practice, I like to give patients a few options and then follow up with them a couple weeks, 1 to 2 weeks after the initial discussion to see if there are further questions and then move forward with starting treatment. I can't stress the importance, especially for those that are newly diagnosed, to initiate treatment as soon as possible. We know that patients that start treatment early on are less likely to have further relapses, and disability progression. Prior to the introduction of disease-modifying therapy, about 50% of patients 10 years after the diagnosis would need some type of assistive device to ambulate. That number has significantly declined. Maybe between 10 and at most 20% of patients fall into that category, and that is due to disease-modifying therapy. You have to remember that the goals of the treatment are to reduce relapses, MRI changes, and disease progression. They unfortunately will not reverse what damage has been done. So it's so important to start treatment to prevent that damage. Hopefully in the future, we will have medication options that might help reverse the damage. And there are many clinical trials that are looking into this currently. So I like to break the medication into roughly 3 categories. Medicines that have modest efficacy, and that includes Glatiramer acetate, which is Copaxone, the Interferons, and then Teriflunomide, which is Aubagio. These medications are ideal for newly diagnosed patients that are presenting with mild symptoms, maybe only a few MRI lesions. Then there's a class that I term moderate efficacy, and that would be the Fumarates and the S1P agents. And most people would agree that the S1P agents are probably a little bit more effective than the Fumarates. And the medications with the highest efficacy would be our infusions, the Natalizumab, anti-B cell therapies, Ocrelizumab and Rituxan, but also the injectable therapy, Kesimpta, and then an oral therapy called Mavenclad or Cladribine. Lemtrada is also a very effective medication, and we'll briefly talk about it, but it's not frequently used given potential side effects. And both Cladribine and Alemtuzumab are usually not used as a first-line treatment. There has been more of a trend in the last several years to use higher efficacy medications at the beginning of the diagnosis. In the past, most clinicians would use modest efficacy medications and make a change when potentially a relapse or a new MRI lesion would occur. But there are studies indicating that if patients are treated with high efficacy medication at the onset, they typically do better down the line. However, there are potentially more side effects, including safety issues associated with the high efficacy medications. So we're always looking at potential benefits versus risk. So breaking down the high efficacy medications for the treatment of the relapsing forms of MS. I'm going to start with Natalizumab, which is Tysabrl. This is an IV infusion that is given every 4 weeks, and patients are typically at the infusion center for 2 to 3 hours. And within the first year, you need to wait at least an hour after the infusion in case you have any type of reaction. There was a recent study, which we participated here at Providence, that showed that extending the dosing after a year to every 5 to 6 weeks may be just as effective and may reduce the risk of the brain infection called PML. How does Tysabrl work? In multiple sclerosis, a subset of your white cells, specifically lymphocytes, are overactive, and Tysabrl binds or attaches to the lymphocytes to a specific receptor or key, and that key is needed to cross over from the blood into the brain. And because that key is no longer functional, the lymphocyte cannot go over into the brain or into the spinal cord. Therefore, this results in less inflammation. One potential downside is that you have less white cells circulating in the spinal fluid, so then potentially you might be at a little bit higher risk of infection. So potential side effects include infusion reactions, although they're not very common, and typically if they do occur, they'll occur after the second or third infusion. And overall, there may be a slightly higher risk of infections on Tysabrl, but Tysabrl actually does not lower your white cell count. Actually, when you check blood in patients on Tysabrl, their white cell counts actually go up slightly. But Tysabrl does carry a risk of a brain infection called PML. The workup required prior to starting on Tysabrl includes getting laboratory testing, checking your cell counts and liver function test, and then also a blood test for the JC virus. These labs are typically performed every 3 to 6 months, and the JC virus testing is usually performed quarterly after the first 2 years of being on Tysabrl. An MRI is also performed prior to starting the medication, and then usually yearly within the first couple years, but then after 2 years, because the risk of PML does go up, MRIs are typically performed every 6 months. So talking more about progressive multifocal leukoencephalopathy, which we use the term PML, it is again associated with a virus called the JC virus. And that virus is quite common. It's estimated that 50 to 70% of people have the JC virus, and we don't know how it's transmitted, and is typically not associated with any symptoms. The virus is in the body but is dormant. However, when you're exposed to certain medications, that virus may then cross over into the brain and cause an inflammation, an infection, which we term PML. When you have the JC virus checked, if you're positive, it will report an index, and this reports sort of the concentration of the antibodies to the virus. And there's evidence in Tysabrl patients that the higher the index, the more likely you're to develop PML. So as you can see in this table on the right, that really in the first 24 months of treatment, the risk of developing PML is extremely low, especially if your index is 1.5 or less. And then you can see that the risk does slightly go up the longer you're on Tysabrl, especially after 2 years. And that risk really jumps when you have an index above 1.5. As you can see in this table, the estimated risk if you are JC virus positive and have an index above 1.5 is roughly 1 per 1,000 within the first 2 years of treatment. But then that increases to about 8 per 1,000 after 2 years of treatment. We spend a great deal of time talking about PML because it is also associated with other medications, although Tysabrl carries the highest risk. However, PML is very uncommon. And in our MS center, we've actually only had one case of PML, which occurred over 10 years ago. However, again, it may occur with this medication despite close monitoring. Symptoms of PML can be very similar to multiple sclerosis, although they typically develop over days or weeks, and they can be associated with loss of vision, weakness, problems with speech, and memory loss. And like I mentioned, there's a blood test that can be performed to identify if you have the JC virus, and that has to be completed at a Quest laboratory. MRI can also help distinguish if someone has PML, and we also will do a spinal fluid examination where we can check for the JC virus within the spinal fluid. So on the right is an MRI identifying a patient that has PML, and what you're seeing is the cerebrum, or the main part of the brain, and the white area is where there's inflammation and infection due to the JC virus. So this looks much different than multiple sclerosis. Multiple sclerosis, the lesions are usually relatively discrete, and this you can see it's very confluent. But sometimes it can be difficult to distinguish, and sometimes we see these changes prior to a patient having any symptoms. If a patient develops PML on Tysabrl, we will stop the medication, and sometimes we'll offer what we call plasma exchange or plasmapheresis, which will help take off the Tysabrl more quickly and allow the immune system to recover. Again, the risk of PML drastically increases after 2 years if you do have the JC virus, and possibly by extending the dose to maybe every 5 to 6 weeks, that may help reduce the risk of PML. If one develops PML, usually you're left with some symptoms, and PML potentially can be fatal. Transitioning to anti-B cell therapy, and there are several medications within this class. Ocrevus or ocrelizumab was approved in 2017, and that is an infusion that's typically given over 3.5 hours. But most patients are at the infusion center for 5 to 6 hours because you also do need to wait at least an hour afterwards to make sure you do not have an adverse reaction. If you've been on Ocrevus for over a year and you're tolerating it well, you may potentially be, maybe it's possible that your infusion time may be decreased to 2 hours, and I would recommend you talk to your clinician about that. Because you can have a reaction, which again is more common with the first or second infusions, with each infusion though, patients will receive Tylenol, an antihistamine, typically Benadryl, and a small dose of a steroid, Solumedrol. Infusion reactions typically occur within the first hour of treatment, but may occur up to 24 hours after treatment. And most patients find that the infusion reactions are mild, maybe experiencing itchy ears, scratchy throat, possibly developing a rash, and sometimes patients can have some shortness of breath. If those occur, it's important to make sure you let the nurse know, and he or she will give you additional medication to help with the reaction, and likely the medication will be stopped, but once the side effect resolves, then the nurse will turn back on the infusion. Afterwards, patients may experience some fatigue from the medication, especially with the first few treatments, but most patients are able to go back to work or resume their regular activities of daily living the following day. Side effects besides infusion reactions include possibly increased risk of infections, particularly respiratory infections. There's also possibly an increased risk of breast cancer. In the clinical trials, there were 6 cases of breast cancer, but there were none in the patients that were not receiving Ocrevus. However, as women have been followed long term, the rate of breast cancer seems to be in line with the general population. That said, we do recommend that women stay up to date with their mammogram while on Ocrevus. The workup is relatively simple, which includes laboratory testing. We also check for hepatitis B and hepatitis C. If you have a hepatitis B infection, the medication may be contraindicated. And then we also talked about getting a mammogram prior to starting, and for most patients, yearly while on the medication. Labs are typically checked within a month of each infusion, just to make sure that your cell count is not too low. We also follow some proteins called immunoglobulins. There are some suggestions if those are too low, that may put one at higher risk of developing an infection. Ofatumumab or Kesimpta is a cousin to ocrelizumab or Ocrevus, but this is an injection that is done weekly for the first 3 weeks and then monthly thereafter. And it's a subcutaneous injection, which goes right underneath the skin. Some patients may take medications prior to the injection, and that will depend on your clinician. So typically in my practice, I have patients take Tylenol and antihistamines such as Zyrtec or Benadryl for the first 4 weeks to try to minimize any side effects. Some patients may experience some flu-like side effects, especially with the first couple, but they typically resolve afterwards. Again, infections are potentially more common, including respiratory infections. The workup is relatively similar to most of our medications, which includes laboratory testing prior to starting, and then we typically will repeat those labs every 3 months within the first year, and then 6 months thereafter. Rituximab is very similar to ocrelizumab or Ocrevus, and there are what we call biosimilars, so there's sort of generic versions of rituximab or Rituxan. Interestingly, rituximab is not FDA approved actually for the treatment of MS. However, there have been some studies that indicate that it is very effective in the treatment of MS. If you have Care Oregon, this is the preferred option over Ocrevus. I'm not going to talk too much about future treatment options. However, likely later this year, there will be another medication within this category called Ubli. And this is also an IV infusion that's given every 6 months. One potential advantage is that the infusion time is much shorter, possibly an hour for each infusion. So how do these medications work? So as I mentioned earlier, MS is due to an overactive immune system, particularly a subset of cells called lymphocytes. And within lymphocytes, there are B cells and T cells. And medications such as Ocrevus, Kesimpta, and Rituxan work on B cells. They attack a receptor on B cells called CD20. And again, that results in damage to those cells. And so then you have less of those cells circulating throughout the system. On the bottom of the diagram, you see that there is something called an autoreactive T cell. And to the right of that, you see natalizumab. And again, natalizumab is binding to this receptor, which prevents that cell from crossing over from the blood into the central nervous system. When those cells are over in the central nervous system, that causes them to produce chemicals, which we call cytokines, and also antibodies. And that may lead to activation of other cells, which may cause damage to the nerve. And you can see an example of a neuron on the far right. Underneath the myelin, which myelin is represented by the light blue, is an axon, and the axon is what's transmitting the electrical signal. You also see attached to the myelin to the left is something called an oligodendrocyte, and that makes the myelin. And it's possible in MS patients that those cells do not work as well, and we don't know exactly why. And unfortunately, as we get older, the cells are not as effective as well. There have been several medications looking at trying to stimulate oligodendrocytes, and one was called anti-LINGO. Unfortunately, that medication was shown not to be beneficial in promoting extramyelin. However, again, there are other clinical trials looking at myelin repair. This is another slide depicting on how medications such as Ocrevus, Kesimpta, and Rituxan work. Throughout our body, we have different types of B cells. So Ocrevus only affects and Kesimpta and Rituxan only affect the B cells that have the CD20 receptor. It does not affect the cells that are to the left, which I call the baby B cells. So that's why the medications have to be redosed, because those cells will grow up and they will develop that receptor. And so then again, the medications will help then eliminate those cells. They also don't affect the cells to the right, particularly plasma cells. And plasma cells are extremely important because they have memory against previous infections. So they help prevent infection and they secrete what we call antibodies. So there is some effect on reduction of those antibodies, but not a drastic effect. So that's why infections, they do occur, but most of them are relatively mild. Shifting to Cladribine or Mavenclad. Now, this is typically not a medication that is used as a first-line medication. So it would be rare for someone who's newly diagnosed to initially start this medication. However, it is a very effective medication, and the dosing is quite convenient as there are 2 courses which consist of 2 cycles. And the dosing is based on weight. So patients will take 1 to 2 pills daily for 4 to 5 days, and then we'll repeat that a month later. They will do the same thing a year later, which is course 2, and then the goal is that they may not need to be on any further treatment after completing course 2. It works by resetting the immune system. And it's very well possible that the vast majority of patients would not need to be on any further treatment after those 2 courses. Like all the medicines that we've discussed, there's potentially a higher risk of infection. One infection to point out are herpes virus type infections, which can include cold sores, genital herpes, and shingles. If a subset of your white cells drops too low, then we recommend that patients start acyclovir or valcyclovir to help prevent these infections. At the time of taking the medication, patients may experience a headache, upset stomach, and potentially there may be a higher risk of cancer, which has resulted in some hesitancy in prescribing the medication. However, less than 1% of patients experience cancer in the clinical trial with the dose that we currently use to treat patients with the relapsing forms of MS. In the clinical trial, there were 10 patients that experienced cancer and 3 patients in the placebo group. These trials were conducted over 10 years ago, and so we've been able to follow patients long term, and the rate of cancer seems to be in line with the general population. So the workup before starting Mavenclad includes laboratory testing, very similar to the testing that we do for most of our medications, and it's also important to make sure that all your cancer screening is up to date. And then an MRI needs to be performed within 6 months of starting, which is typical for most medications. It allows us to establish a new baseline. And then testing afterwards includes some blood tests. We do a cell count 2 months after starting because that's when your lymphocytes may be at their lowest. And we already discussed that if they are low, then we may recommend starting a medication to prevent these herpes type infections. And then an MRI is repeated prior to starting course 2. Patients are followed after that with frequent visits and MRIs. If there is evidence of a relapse or MRI progression, then we may need to look at other treatment options, but at this time it's not recommended to have any further doses of Mavenclad. Some takeaway points from Mavenclad. As I mentioned earlier, it's not recommended as your first treatment. Possibly no further treatment would be needed after the first 2 courses. And it's very important that both men and women use appropriate contraception while on Mavenclad. So this is one of 2 medications where men also need to make sure that appropriate contraception is being used. Women should also use a second method of contraception at least 4 weeks after their last dose of Mavenclad. Alemtuzumab, which is Lemtrada, again, another medication which we typically do not use as a first-line medication. The dosing is somewhat similar to Mavenclad, although this is an IV infusion, so it's given daily for the first 5 days, and then a year later, it's given daily for 3 days. And additional doses are allowed if someone has disease progression while on Lemtrada. Lemtrada is not used very often because of potential side effects and safety issues. Infusion reactions are pretty common. There have also been some reports of strokes occurring shortly after the infusions. And there's a risk of developing other autoimmune conditions, with almost a third of patients developing some thyroid dysfunction. But there's also been reports of patients developing issues with their platelets, which can lead to bleeding, as well as issues with their kidney. Possibly there's also an increased risk of cancer and infections. Because of the safety issues, blood work is done monthly for for 4 years after the last treatment. So keep an eye on specifically the thyroid function and platelet count. Moving to moderate to high efficacy treatment options, and for the relapsing forms of MS would be the S1P therapies. And there are 4 medications now in this category. Fingolimod, which is Gilenya, and again, that's been available the longest since 2010. Ozanimod, which is Imposia. Ponesimod, which is Ponvory. And Siponimod, which is Mayzent. These are all pills that are taken once a day. They work by, again, binding to a receptor on white cells. And this receptor is needed for the white cell to leave the lymph node. So these cells are circulating through the blood and your lymph system. And if you're on one of these medications, once the cell enters a lymph node, it's stuck there. However, once you stop the medication, then the lymphocytes are able to exit the lymph node and do what they were doing previously. So by having less of these cells, then you're less likely to have a relapse on these medications. Potential side effects include an increased risk of infections, particularly respiratory infections, and there have been cases of PML reported on these class of medications, although the risk is much lower compared to Tysabrl. With the first few doses, there may be a reduction in the heart rate, so patients may experience some lightheadedness or more fatigue, and possibly notice a headache around the time of starting the medication, but typically if that does occur, that resolves after a few weeks or a couple months. Possibly there's also a higher risk of skin cancer, specifically basal cell carcinoma, which is not a big deal in the cancer world because it does not spread or metastasize to other places, but also something you do not want to leave unaddressed. So the workup for this class of medications includes blood test with, if you're starting Siponimod, which is Mayzent, there is an additional blood test. It is a genetic test, and this helps to determine the appropriate dose for Mayzent. Eye exam is recommended prior to starting the medication because these medications can cause some swelling in the back of the eye, so it's important to get a baseline exam, and then an exam is repeated 3 to 4 months afterwards. Patients may develop some blurriness in their vision if they do develop what we call macular edema. If that occurs, we have to stop the medication, and the vision will typically go back to where it was before. This really occurred very infrequently in the clinical trials, less than 1% of patients. It's actually not required for patients that are starting Symposia, although as a precaution, I like to have my patients get an eye exam, and it's important for MS patients to at least get an eye exam every 2 years. We do an EKG to make sure that the heart rate is not too low. Again, if the heart rate's too low, you may not be a candidate for starting these medications. And also, if you've had any recent heart conditions or stroke within the last 6 months, these medications are not recommended. In our clinic, we also recommend patients see a dermatologist roughly around the time of starting and then yearly because of that potential risk of skin cancer. And for patients that are starting Gilenya or possibly have too low of a heart rate, you'll need to be observed for the first dose. And so for Gilenya, that can be done in a clinic, or there are outpatient centers that monitor patients, and that typically will last for 6 hours. It's also important that if you miss several doses, especially early on, you may have to repeat the first dose observation, or with the other medications, there is a titration up to the maintenance dose. You may have to repeat that. So please keep your clinician informed if you do miss any doses, because potentially you may have to restart that process. There's testing afterwards, which includes laboratory testing, usually every 6 months. We talked about the eye exam 3 to 4 months after starting these medications. And then for this class of medications, I prefer yearly and then seeing a dermatologist yearly. So some takeaway points, because there's multiple agents within this category, and how do you choose which one? Gilenya has been around the longest. It was first approved in 2010. First dose observation is required. So for some patients, that's not ideal because it takes maybe an extra day away from work or from family. Mayzent was actually studied in patients with secondary progressive MS, so there may be some benefit for patients that are transitioning to that form of the disease. Additional laboratory tests is required, although typically that's not a big deal. Symposia is the easiest to start because an eye exam is not required. There is some good data on reducing brain atrophy with this medication. So potentially there may be some benefit in slowing down progression and particularly cognition. Although there are potentially some drug interactions with this, so if you're on an antidepressant, it is recommended not to start Symposia. and Ponvory is the newest one. And one potential advantage is it's the shortest acting. So if you have side effects, then we can stop that, and your cell count recovers quite quickly compared to the other three. This potentially is not a great treatment option for women of childbearing age, especially if you're thinking of having a child in a year or two, because some of these, for example, Imposia, it's recommended you stop the medication and then wait 3 months before trying to start a family. And there is some evidence that if you stop these medications, you can have rebound of the disease, including a severe relapse. And so I typically don't like to start these medications in women that are thinking of starting a family. If that's the case, and we decide to move forward with these therapies, Ponvory may be the best option because it lasts the shortest. Patients can start to consider starting a family roughly 2 weeks after stopping the medication. Moderate efficacy treatment options. These are going to be our fumarates. So most people are familiar with Tecfidera, and then we now have Vumerity and Bafitarum. And both Tecfidera and Vumerity are metabolized or broken down to monomethyl fumarate, which is Bafitarum. So they all work very similar. And exactly why they work is a little bit unclear. And this class of medications was initially used for the treatment of psoriasis in Europe and was shown to be effective in patients with multiple sclerosis. It may work as an antioxidant, and also it does lower a subset of white cells, and which likely provides some additional benefit. Flushing is probably the most common side effect. You may turn bright red for 15-30 minutes. That may occur anytime throughout the day. If it's an issue, taking aspirin in the morning prior to taking your medication might help minimize the flushing. This may be more prominent also once you start it, but may improve over the course of time. And taking it with food may also help minimize the flushing. GI symptoms, including nausea, bloating, feeling of fullness, diarrhea, also can occur with these medications. Typically, if they do occur, they're going to resolve or get better after the first few weeks. There is some thought that maybe the GI side effects are less prominent with Vumerity and Bafitarum. And I forgot to mention that with Tecfidera, there is now a generic formulation. So many patients who decide to go on Tecfidera will be on the generic formulation. And from my experience, patients tolerate the generic formulation just the same as they do with a brand Tecfidera. These are very easy to start. All you need to do is have some blood work done, and then we repeat the blood work every 6 months. Some additional information about this class of medication. Mentioned that there's a generic formulation for Tecfidera. So to be honest, if you do decide to go on a fumarate, a lot of times we don't have too much of a choice in terms of which one that you will go on. A lot of it depends on insurance. GI side effects are the most common within the first 4 weeks, maybe less so with Vumerity and also Bafitarum. And taking it with food may also help minimize these side effects. However, one thing to note, if you are on Vumerity or getting ready to start Vumerity, it's recommended that you not take it with a high caloric meal. So if you're going to have a big dinner, then maybe taking it an hour before dinner or potentially at least 2 hours afterwards, maybe before you go to bed. It's also recommended that you not take it with alcohol. Again, you still potentially can have alcohol at lunch or dinner, but you should not take the medication at the same time. And it's possible that if you do, or if you have a meal that has a lot of calories, you just may not absorb it as well. So then it may not be as effective. It's not a safety issue. And if you by chance do that occasionally, it's not going to have a negative impact on your disease. There have been a few cases of PML associated with these medications, although not very common, roughly 10 to 15 cases. And they mostly occurred in patients that were older than 54 and also had a low subset of their white cells called lymphocytes, which is called the absolute lymphocyte count. And so again, those are counts are followed while you're on the medication, and if they drop to a certain level, your clinician may ask you to discontinue the medication. You have to remember there's always going to be potential risk with all these medications, and you have to look at potential benefits versus risk before stopping a medication. And lastly, I just wanted to review treatment that has modest efficacy. And the first one is Teriflunomide or Aubagio, and that is a pill that's taken daily, which has been available for, I guess, almost 10 years now. And it works by blocking an enzyme that rapidly producing white cells typically use. And so if you're able to block this enzyme, then those cells are not available to cause inflammation, which then can trigger a relapse and new MRI changes. The most common side effects include loose stools, although most patients find it manageable, and constipation is not an uncommon side effect in MS, so some patients actually welcome that potential side effect. It can also cause some hair thinning, and that may occur 2 to 3 months after initiating the medication and last for a few months. You just may notice that when you're brushing your hair, combing your hair, that more hair may come out. But most the hair typically grows back after 6 to 7 months after beginning the medication. Headache may potentially be a little bit more common, and elevated liver function tests can occur, not very common, but can lead to severe liver damage. Therefore, we do check liver function test monthly for the first 6 months, and likely your clinician will continue checking those, but maybe every 4 to 6 months thereafter. We do some additional blood tests, including checking for tuberculosis. If if you've been exposed to tuberculosis, then it's recommended that you not go on this treatment. And that's the case for many of our MS therapies. It's important to make sure that you use contraception. This is the case for both men and women. Possibly there may be a higher risk of spontaneous abortion for women that are on this medication, or if their partner is on this medication, because it can be transmitted in the semen. Glatiramer acetate or Copaxone. There are two formulations. So originally, there was a shot that was daily, but now there's a newer formulation that's 3 times a week. This is a subcutaneous injection, and there is also a generic formulation of this medication for both the 20 and 40 milligram doses. Site reactions are the most common. So it's not uncommon for people to experience redness, irritation, itchiness with an injection. Again, most people find that those are manageable. For some people, using heat helps. For others, using cold or maybe a cream such as a Benadryl cream might help. And usually they do get better over time. On occasion, patients can have what we call a systemic reaction. So shortly after the injection, there's this sense of panic where it might have some chest tightness and shortness of breath and may feel very hot and sweaty. That may last for several minutes. There's nothing serious that's occurring, though I know it can be very scary. This may occur once, it may occur a couple times a year. Unfortunately, there's no way of predicting it or avoiding it. You don't need to go to the emergency room, although I guess if you're experiencing those symptoms outside of the injection, then you do need to seek medical attention. But if it's occurring shortly after that, then it's due to the Copaxone. Copaxone is the easiest medication to start. We do not need to do any additional testing, no lab testing, no EKG, no referring you to see any other physicians, which makes it nice. However, the downside is it's probably our least effective medication. But for some patients that are presenting with mild disease, this may be a good option for them, especially if you're concerned about safety, particularly risk of infection. And then lastly, I'd like to discuss the interferons. And there are 4 options or 5 options. So Avonex, which is an injection that goes into the muscle, and this is once a week. Betaseron and its cousin Xtavia is a subcutaneous injection, which is every other day. Plegridy, which is also a subcutaneous injection, but that's given every 2 weeks. And then Rebif is a subcutaneous injection, and that is given 3 times a week. So Plegridy is the least frequent of the 4 options. What limits these medications? Well, one, they're injections. So for some patients, that's not appealing, understandably, but it can cause flu-like side effects. And so having muscle aching, chills, fever after the injection can be for some patients quite bothersome. Some patients do take ibuprofen or Tylenol prior to the injection, and then after the injection, which does help minimize the side effect, and ibuprofen actually may work better than Tylenol. Injection site reactions can also occur, especially for the subcutaneous injections, more so with the Plegridy. We do blood work prior to initiating these medications, including your cell counts, liver function tests, and thyroid testing, and typically those are repeated every 6 months. So I would like to thank you for your attention today. Know that there are lots of treatment options, which is great, but I know also it can be quite overwhelming. And Noah mentioned this earlier, but for patients who are newly diagnosed, I can't stress the importance of you starting treatment early on in your disease, even if you feel like you're doing well. And this will help prevent further relapses and reduce your chances of transitioning to progressive disease. For those that are not happy with their current treatment option, may that be due to tolerability issue or you're concerned about your disease progressing, it's important for you to be proactive in communicating that to your clinician because there are other options. Again, thank you on behalf of my colleagues at the Providence MS Center in Portland, Oregon. Take care.